All right, in this explainer, we're going to build a solid clinical framework for how to approach syncope. Now, this is a super common presentation, but it's one that can signal anything from a totally benign faint to a life-threatening emergency. Our goal here is to give you the reasoning, the clinical thinking to tell the difference. So let's get started.
So let's just jump right into a scenario you've probably seen or will see. You've got a 72-year-old man, he's in for his appointment, and he just collapses. He's unresponsive for, say, 15 seconds, and then just as suddenly, he's back with you. So what's going through your head? Was that just a simple faint? Could it have been a seizure? Or, and this is the one that keeps us up at night, is it the first sign of a dangerous cardiac arrhythmia? Your next moves are absolutely critical. And that, right there, is the core challenge of syncope.
So, what that patient experienced was, by definition, syncope. And the definition here is incredibly important. It's a transient loss of consciousness caused by a global cerebral hypoperfusion. The key words are everything here. Transient means it's brief and the recovery is spontaneous. And global means the entire brain's blood supply was cut back for a moment. This is the fundamental physiological event we need to investigate. Now, we also have to talk about its cousin, presyncope. This is that feeling that you're about to lose consciousness. You get lightheaded, maybe some tunnel vision, but you never actually black out. Here's the clinical pearl. From a diagnostic point of view, presyncope has the exact same clinical weight as syncope. It comes from the same underlying problems and demands the same thorough workup. It's a huge warning sign that you absolutely can't dismiss.
Okay, so we have the definition down. Now let's get into the why. Why does the brain just black out? What is the core mechanism that makes the brain so vulnerable to even a tiny interruption in blood flow?
Well, it doesn't matter what the initial trigger is. It could be a heart problem, a weird reflex, a sudden drop in blood pressure. They all funnel down to the exact same final common pathway, a temporary failure of cerebral perfusion. Every single cause we're about to talk about ends up right here. And understanding that really simplifies how we approach the diagnosis.
So to keep our thinking organized, we can group all the causes of syncope into three main pathways. This framework is just essential for systematically figuring things out at the bedside. The first one, and honestly the most critical one, is cardiac syncope. You can think of this as a pump failure. It's a problem with the heart itself. Sometimes it's an electrical issue, like ventricular tachycardia or a complete heart block. Other times it's a mechanical obstruction, like severe aortic stenosis. These are the causes we absolutely cannot afford to miss, because they carry the highest risk of sudden death. Second up is reflex syncope, also called neurocardiogenic syncope. This is more of a wiring issue. It's a glitch in the autonomic nervous system. Some kind of trigger, maybe it's emotional distress, pain, even just a bad cough. It causes this bizarre reflex that makes the heart rate and blood pressure plummet. The result? Not enough blood to the brain. This is the classic mechanism behind a common vasovagal faint, which, thankfully, is usually benign.
And our third pathway is orthostatic hypotension. This is basically a plumbing problem. When the person stands up, their body's automatic response just fails. The blood vessels don't tighten up enough to fight gravity, so blood pools in the legs and blood pressure drops. You see this all the time in elderly patients, especially if they're on blood pressure meds, or really in anyone who's dehydrated.
So with these three pathways in our minds, how do we figure out which one is causing our patient's problem? Well, the single most valuable tool you have is not some fancy scan or blood test. It's a really good, meticulous history. The details of what happened right before, during, and after the event, that's where the crucial clues are hiding.
Just look at how the history helps us tell things apart. For warning symptoms, cardiac syncope is often totally abrupt, no warning at all. Whereas with a reflex faint, the person usually feels nauseous or sweaty beforehand. And here's a huge one for telling it apart from a seizure: the recovery. After syncope, recovery is fast. We're talking under a minute. After a seizure, there's that post-ictal state, that prolonged confusion. These details are absolutely fundamental to your diagnosis.
The history does more than just point to a diagnosis. Its most important job is to help us risk stratify our patients. We have to be detectives, looking for the red flags that point to a high-risk, potentially cardiac cause. We have to separate the simple faint from a ticking time bomb.
And these are the big red flags you have to look for. Syncope during exercise is a huge one. It suggests the heart just can't keep up with demand, pointing to something like aortic stenosis. Syncope while lying down is also very concerning because it rules out any postural cause. And as we said, no warning symptoms at all suggests a sudden arrhythmia.
If you hear any of these in the history, you need to be thinking about an urgent cardiac workup.
And that brings us to the one test that every single patient with syncope or presyncope gets, no exceptions. It's a 12-lead ECG. It is absolutely non-negotiable. You're hunting for any evidence of ischemia, signs of structural problems like LVH, or, most importantly, any conduction issues, a long QT, a heart block, anything that could set the stage for a deadly arrhythmia.
Okay, so let's wrap this all up with a few key clinical pearls, the stuff you really need to remember.
So, to recap, first, remember that syncope is just a symptom of the brain not getting enough blood for a moment. Second, your most powerful tool for figuring out why is a great history. Third, pay super close attention to the red flags, especially syncope with exercise. That's a cardiac cause until proven otherwise. And finally, the cornerstone of your workup, every single time, is a 12-lead ECG.
And if you remember nothing else, remember this: syncope is not the final diagnosis. It's the presenting symptom. It's the question that demands an answer. And our job as clinicians is to use our skills to uncover the underlying cause. Syncope is the question. We have to find the answer.